Hello, I'm Peter Bovey. I'm a general surgeon and I'd like to talk to you about peripheral nerve compression in the upper limb, specifically carpal tunnel syndrome and ulnar nerve compression at the elbow. These are both quite common conditions and I get referred many patients with them, particularly carpal tunnel syndrome. Carpal tunnel syndrome is caused by compression of the median nerve in the wrist. It's a nerve that supplies sensation to the thumb, index finger, middle finger, and this side of the ring finger. It also supplies the muscle that's in there in the palm. Why it's compressed in the wrist, we don't really know. Basically, there are bones across the floor of the wrist. There's a column of bone on either side of the wrist, and across the top there's a thick ligament, and the nerve runs under that, along with the long flexor tendons, the ones that do this. And in some people it just seems to run out of room in that tunnel. It's probably a combination of factors. Certainly we know that carpal tunnel can be familial. A lot of people say that it's constitutional, in other words, you're born with the predisposition to the condition. Presumably in these people we're just born with a narrow carpal tunnel. Certainly I think in some people the transverse carpal ligament gets thickened from hard work, repetitive work, and in others the flexor tendons swell up because of some tendinitis, causing swelling of the tendon sheath, and the result is the nerve gets compressed. Basically the symptoms of carpal tunnel: altered sensation in the median nerve distribution, in other words, pins and needles or numbness affecting the thumb, index finger, middle finger, or that side of a ring finger. And this is usually associated with some pain. Often the symptoms begin at night time. People wake up with a numb hand or with pain in the arm. Typically they complain of pain in the hand, but it can radiate up the arm and sometimes all the way up to the shoulder. With the passage of time, the symptoms can become more continuous. Usually people will complain of numbness whilst driving or using the phone, reading a book, but in time it can become numb all the time. There's also associated with this sometimes weakness in the hand, and some people tend to drop things. It's probably a combination of clumsiness due to altered sensation and some weakness. The symptoms are usually quite typical, and when they are, I don't think any investigation is needed. But if they're atypical, what we'll usually do is organise nerve conduction studies, and these are done by a neurologist. Electrodes are put on the hand and the arm. Very small electrical impulses are sent along these, and the neurologist can look at the nerve function in this way. I think in early carpal tunnel syndrome, sometimes the nerve conduction studies can be normal. You wouldn't see that they were abnormal unless the patient had symptoms at the time. But in most of the patients I see, the nerve conduction studies are not normal. Some people have ordered wrist ultrasounds, and certainly abnormalities can be seen in carpal tunnel syndrome, or flattening of the nerve or thickening of the nerve. But I don't think these are usually particularly helpful. Likewise, I don't think that radiology in terms of plain X-rays or CTs are indicated for the condition. In early carpal tunnel syndrome, where the symptoms are intermittent, they'll often improve just with rest. A lot of people will say that their symptoms get better whilst they're on holidays, or if they avoid particular activities that seem to exacerbate the symptoms. Certainly we know that people doing more manual jobs that involve a lot of use of the hands are more prone to getting these symptoms. When the symptoms are early, some people don't require immediate surgery. People who get symptoms mainly at night are often helped by using a night splint, which stops them bending their wrist either direction, which can help prevent symptoms. A steroid injection into the carpal tunnel can provide relief of symptoms for some people. Sometimes this relief will last for months, but it nearly always recurs. Some women develop symptoms of carpal tunnel during pregnancy, and these will often resolve after they deliver the baby. Once the symptoms start to get bothersome, surgery should be considered. What we do to fix carpal tunnel syndrome with an operation is a carpal tunnel release. This can be done in one of two ways. The way that I normally do is an open technique. It involves making an incision about that big in the palm, dividing the transverse carpal ligament, or some people call it the flexor retinaculum, releasing the pressure on the nerve and sewing the skin up. I normally do this in my office under local anaesthetic, and it takes 9 minutes to do. There is another technique, and that's an endoscopic technique using something that resembles a small arthroscope. An incision is made here on the wrist and here in the palm, and the instrument is passed underneath the transverse carpal ligament and has a blade in it, and the ligament is divided from the inside. That operation requires a general anaesthetic. It's said to result in less post-operative pain and earlier post-operative recovery. But if you think about the problem is that the nerve is compressed in the carpal tunnel, and this instrument, although it's small, occupies a size, and therefore introducing the instrument into a carpal tunnel can indeed compress the nerve more. And certainly there have been incidences of tendon injuries and injuries to the median nerve after endoscopic carpal tunnel release. I haven't practiced this technique, and certainly I've seen a few bad results from it. Indeed, one of my patients who recently went to a major city to have a joint replacement had an endoscopic carpal tunnel release while he was there and came back complaining of continuous numbness in the median nerve distribution and is quite unhappy. I know of someone else who's got a permanently sensitive middle finger after an endoscopic carpal tunnel release. The advantage of the open operation is that it can be done under local anaesthetic. Most people having the operation are happy with the results. The ones that aren't happy are firstly the ones that don't actually have carpal tunnel syndrome. And if we're in any doubt, we'll get nerve conduction studies done. But there are other conditions that can mimic carpal tunnel syndrome, particularly cervical disc protrusion causing nerve compression in the neck. The other group of people that may not be completely happy with the operation are those that have waited too long. And if you wait until you've had continuous pins and needles or numbness for many months, or this muscle here wastes away, the nerve may have been irreversibly damaged. There's usually improvement after surgery in that the patients don't complain of nocturnal pain, but sometimes the sensation doesn't return to normal, or it may return to normal very slowly. And I've seen someone take 12 months before they thought the sensation had returned to normal. And usually in that sort of case, the first finger to go numb is the last one to recover. I therefore recommend to all patients to have surgical treatment before they have continuous numbness. After the operation, you'll have sutures in the palm of your hand, a bandage on the hand immobilising the wrist. It doesn't immobilise the fingers, and I encourage people to move their fingers post-operatively. I think if you don't, you're more likely to get swelling and stiffness in the fingers. We'll also give you a high arm sling and a script for some post-operative analgesics to take. I normally recommend people put their arm on a small pillow for the first couple of post-op nights to prevent it hanging down, and suggest that they wear the sling for a couple of days. I normally would recommend the bandage to be left on until you see me for your post-op appointment. At about 10 days post-op, we get you back, take the bandage off, remove the sutures, put steri-strips on the palm, and you can start to use your hand. Initially, vigorous finger movements will hurt. Pronation and supination might hurt, and you won't be able to lean on your palm like that. Most people regain most of the function in the hand in the first 2 to 4 weeks. Some people are very slow, have a lot of swelling or stiffness or a lot of pain. I send them to see the hand therapist post-op. Hand therapy is a branch of occupational therapy, but they just do hands. I'm sure everyone would benefit from seeing the hand therapists, but most people don't in fact need to, and because they're not free, I only send a select number of people to see them. But if you're interested in going back to work quickly, seeing the hand therapist would be recommended. I'll give you a sheet with some instructions for exercises to do post-op. I normally get people back for a second post-op review at 6 weeks. A lot of people have symptoms in both hands. In general, I don't recommend having both carpal tunnels released at the same time. In fact, if one does that, most people are rendered helpless, in other words, unable to dress themselves, feed themselves, comb their hair, brush their teeth, or wipe their bottom. If you've got significant symptoms in the other hand, we'll normally look at doing it once you've recovered sufficient function in the first hand. I normally like to do the worst hand first. I've had some people have the other hand done 10 days later because they had such severe symptoms in it and they are so pleased with the result of the first carpal tunnel release. And I've had other people who've never got the second side done, but most people will get it done within the next 6 months. Even if you've got no symptoms in the other hand, I think about 30% of people will eventually develop symptoms in the second hand. There's often a family history of carpal tunnel, and I think if you've had a carpal tunnel release, you should tell your siblings, parents and children what you've had done and what the symptoms were in case they develop the same symptom. A small number of people develop recurrent carpal tunnel syndrome after surgery. I've seen occasions where the ligament seems to have grown back together, but more commonly, scar tissue forms between the cut edges of the ligament and adheres to the nerve. Overall, I think about 1% of people end up having recurrent carpal tunnel syndrome, and some of these come to having redo surgery. The results of redo surgery are very unpredictable. In other words, some people have a good result and some people have very little change in their symptoms. But I think if you do think that it's coming back, it's worth coming back to see me and we might get another nerve conduction study done. I've had one patient need a redo carpal tunnel release inside 12 months, and when I went back in to do the redo operation, it looked as if I'd done nothing the first time. The ligament had not only grown back completely, but was quite thick and compressing the nerve, and it looked like no surgery had been done the first time round. But since I did it, I knew that wasn't the case. The other nerve that can be compressed in the upper limb is the ulnar nerve at the elbow. The ulnar nerve supplies sensation to the little finger, that side of a ring finger, and all the other intrinsic muscles in the hand. The majority of people will have experienced symptoms of ulnar nerve compression at some point in their life. These symptoms are those that you get from knocking the funny bone at the elbow, and this is where the ulnar nerve is compressed. In fact, I have had an ulnar nerve decompression. The ulnar nerve runs between the medial epicondyle and the olecranon here through a tunnel and can be compressed by a ligament. It can also be compressed between the heads of muscle on either side of this groove. A lot of people will have transient symptoms from falling asleep with their lying on their elbow. Sometimes these symptoms will develop if the elbow is not positioned properly during an operation. A number of people get ulnar nerve compression symptoms at other times. It's said that splinting the elbow so that it's straight at night time might prevent symptoms. If you start getting symptoms during the day that are annoying, namely numbness or pins and needles in the little finger or weakness in the hand, surgery can be indicated. In the old days, this involved making an incision at the elbow, mobilising the nerve out of this tunnel and transposing it anterior to the medial epicondyle. We no longer do this operation routinely as it's been found to have no benefit over simply dividing the ligamentous tissue that's on top of the nerve. So basically, a small incision is made at the elbow, We cut down through this ligament, exposing the nerve, and clear all the tissue over the surface of the nerve, upwards and downwards, releasing any compression. It's an operation that can be done under local anaesthetic, but I prefer to do under a general anaesthetic as a day case with a tourniquet. Wound is usually closed with a subcuticular absorbable suture and steri-strips, so that there are no sutures to be removed. A wool and crepe bandage is applied to the elbow and the patient's discharged with a broad-arm sling and a script for some analgesia. This operation doesn't usually cause much in the way of post-op discomfort. The recovery is a bit more unpredictable than with carpal tunnel syndrome. Carpal tunnel is nearly always painful initially, and most people get a good result. The ulnar nerve is compressed a lot further from where the symptoms are than with the median nerve in carpal tunnel. In some cases of nerve compression, the nerve fibres inside the nerve sheaths are actually disrupted. And if this is the case, they tend to grow back at the rate of 1 millimetre per day. It's not very far from where the median nerve is compressed to the tip of the finger, but it's a much further distance from the elbow to the tip of the little finger. And if someone has wasting of the first dorsal interosseous or has had continuous pins and needles or numbness in the little finger for a long time, recovery may be very slow or be incomplete. I've never seen anyone need to have a second ulnar nerve decompression. Some people will have symptoms of both median and ulnar nerve decompression. Usually the median nerve symptoms predominate, and in this situation we'll often do a medial nerve decompression or a carpal tunnel release under local anaesthetic first, and then see whether an ulnar nerve decompression is required. There are people who've got compression of both median nerves and both ulnar nerves. What I'll normally do with those is under a general anaesthetic as a day case, do bilateral ulnar nerve decompressions at the elbow and a unilateral carpal tunnel release, so as not to render the patient helpless. As you could see from the scar on my elbow, I've had one ulnar nerve decompression, but I've not had any symptoms on the other side, and I've been quite happy with the result of my operation. You can also get nerve compression in the foot. There is a condition called tarsal tunnel syndrome. It's quite uncommon. I've never seen one released, and these operations are usually done by a neurosurgeon. If you're referred to me with carpal tunnel syndrome or ulnar nerve compression at the elbow, I'll see you, examine you, take a brief history, and then if it's appropriate, do an operation. I usually do carpal tunnel releases in the office under local anaesthetic, usually on a Friday. It is necessary for you to be driven home afterwards. It's illegal to drive with your hand in a bandage and your arm in a sling. If you're caught, I think it's an offence called driving without paying due care and attention. When I last inquired, it was 1 demerit point and a few $100s in a fine. Once you no longer have a bandage on your hand or your arm in a sling, you will be able to drive. Thank you for listening.